All right, good morning, everyone. This is the Behavioral Health Urgent Care Crisis Stabilization Workgroup meeting. This is our fourth meeting, believe it or not. We've been at this for 4 months, a couple meetings left after today, but we're getting closer. As probably, hopefully, you had a chance to review the materials. We have an emerging set of recommendations related to behavioral health urgent care, and we're making good progress with meetings planned for October and November. So I'm going to start things off. My name is Jeff Vanderplug from CHDI. If you wouldn't mind, please introducing yourself using the chat box. That would be great. And also, just as a reminder, we are recording these meetings and we post the video as well as the meeting minutes and other materials onto the website. I'm going to pull up the agenda just so that we can take a very quick look at that. So today, hopefully everyone can see that. Today we are kind of continuing with our goals. We're going to hopefully get pretty close to a final set of recommendations and ideas around the behavioral health urgent care model. You will have additional opportunities to take a look at it, so don't worry about that. But we're getting very close on that one. And we're also going to spend some time today turning our attention over to crisis stabilization units, which are the 1 to 14 day approach that we've been kind of teeing up for the last meeting or two. And just as a reminder, all recommendations from this work group on urgent care or crisis stabilization units go up to the Behavioral Health Plan Advisory Board, as well as the 12 state department commissioners. So with that, let me just ask Tim if he'd like to add anything, and then we will get going.
Thank you, Jeff. No, good morning, everybody. Glad to see everybody again. Looks like we have over 20 folks already joined us. And I just would reiterate, we are really interested, just because there's so much material that we have to cover. We're really interested in your feedback electronically. So you should have the beginning, an opportunity to review the beginning of our recommendations on the BH urgent care setting, and you should begin to see a structure for us to fill out and to be populated going forward in the next month or so on the crisis stabilization unit. So we'll be talking about those two today, but we're looking forward to ongoing electronic exchange from you as you see areas, particularly of things that have come up here that we didn't capture, be really important for you to communicate that through us. All right, thank you, and back to you, Jeff.
All right, thanks, Tim. And Elise, if you wouldn't mind, let's go ahead and pull up the urgent care model parameters document. And as I do that, I just want to welcome Elise to the team. She has been at CHDI for a few years and is now the senior project coordinator on this behavioral health plan implementation project that we have going on. So you will see her at the rest of these meetings, and if you also attend the data integration or alternative payment methods work group, you'll see Elise there as well. So I am thrilled that she is on board. It certainly is going to lighten my load a lot, and she brings a lot of talent and ability and knowledge to the group. So we're excited to have her join the team. Okay, so with that, let's dive into this. Elise, this is actually the CSU model. If you could pull up the urgent care model first.
Sure, I apologize.
So on the urgent care model, the first couple of pages, as that starts to come up, the first couple of pages start with a background and rationale, which just sort of sets the table for why a behavioral health urgent care is needed. And then the second page of the document places the behavioral health urgent care within a systems context, which includes a number of recommendations for other elements of the continuum. So we thought that both of those sections to start the document would be really important. Before we get into kind of the nuts and bolts of the goals and the service delivery, does anybody have any comments or things that they want to say about the first two pages on background rationale or on the systems context and some of those themes?
So this is Carl Schissel from CHA. Good morning, Jeff.
Morning.
Yeah, I'm thinking this morning about our target audience and what they're asking of us, in the short term. This is, by my estimation, keeping in mind that I'm not a clinician or a direct service provider, but as a representative of a trade association, but our members are. The prospect of creating a new level of care to fit in an existing system, operationalizing it, creating funding sources, and having those in reimbursement rates for services, finding the staff to populate that level of care, and then creating a sustainable, financial model, to me are sort of supreme challenges. And to take that on as we have, thankfully, I'm grateful for every second we spend talking about this, so don't get me wrong. I wonder how that fits within the context, of our current crisis, in behavioral health, as I think about how long it takes to do any one of those things, much less, from a physics perspective, finding the physical space, number one, and then creating that space, in order to provide the care. And I'm just thinking about, how the healthcare landscape has evolved over the 10 years or 11 years I've been at CHA, to one with care essentially going out to where the people is, in terms of more clinics, more urgent care centers, freestanding EDs, et cetera, et cetera. So what I'm trying to figure out is what our audience is expecting from us, because it seems clear to me that if the legislature or the advisory board or the agencies are looking for a solution in this area that they can implement immediately to address the crisis, it seems to me that this is going to be very challenging on several levels. I'm sure on levels in addition to those I've mentioned. So I wanted to raise those key challenges, put them into context, and just make sure that as this group develops its recommendations, that we lead with, what we perceive to be the real challenges of doing something right away. Because if the legislature has, or the governor has, tens or hundreds of millions of dollars to earmark to implement immediate improvements to the children's behavioral health system, and address this need, this falls within the spectrum of those potential solutions in some way. And I'm just wondering, how we're going to make it all, make sense when we ultimately deliver our report to those constituencies. So
Okay.
Thank you for letting me share what's on my mind this morning.
No, I appreciate that. I give Tim a chance to respond to that. And actually, Elise, I don't know if anybody else was seeing a blank screen. I was seeing a blank screen up there earlier. Yeah, it looks like some heads are nodding. So, but Tim, do you want to respond to that while we pull the document up?
Yeah, I think what we've all have seen and discovered as we continue to move forward on this project, that this would be a gigantic project. There's no way around that. But that said, I think our deliverables and our directions were pretty clear. Our goals on the agenda are pretty clearly stated. I think we're close to delivering what we believe, this group believes, us collectively believing, will be important components of these two models of care to be implementing in Connecticut. That's our charge, and that's what we're doing. I do think our attempt, Jeff and I's attempt to put this background there and is to acknowledge that you can't just build a new level of care in isolation of not paying attention to the rest of the system. So we just want to make it clear that we were reflecting the conversations that occurred here. So for example, more than one occasion, the notion of increasing inpatient beds has come up here. So is that our job to tell and provide recommendations about how to do that? No, but it's important context. Likewise, DSS, Medicaid rates, reimbursement rates, those all will need to be worked out. Is that this group's job? I'm not sure. Do we get marching orders later on? Possibly, I don't know. But similarly, the other issues you discuss citing issues, et cetera. So if we had recommendations ready to go tomorrow, there's still legislation to be had, there's still procurement to be done, there's still citing to be occurred, and relationships and collaborations to be done. So I just don't want the overwhelming nature of this to sidetrack the concrete steps we need to take to deliver this and let this unfold. That said, we're not insensitive to numbers of kids waiting today in the ED. So we would, there's other projects that are attempting to address that more quickly. So, but I think bottom line is from my perspective, we have more momentum and more direction and more support going in this direction than ever before. And I think we need to capitalize that and take it as we can and keep moving. And let's see what the barriers that continue to pop up are and try to just overcome them. So that would be my response.
So I'll take the liberty of replying to your response and then afford anyone else in the work group an opportunity to speak. You know, having been a policymaker many decades ago, when in crisis, and I worked in finance and public health when I served in the General Assembly for many years. You know, when faced with a crisis, especially living election to election, which are still 2-year terms, you know, the challenge became, what can we do right now to address this immediate need? And you know, and a solution that I think might take years to implement and potentially run into substantial barriers or roadblocks, or be, you know, ultimately unachievable due to, let's say, a reimbursement rate that isn't sufficient or a lack of staff. All those challenges generally impact how long it takes to achieve something. And so I think that if I were sitting, and I am one of the tri-chairs of the advisory board, but in which we aren't a group that has any authority, we serve in an advisory function. You know, I think developing some sense of, you know, what could be very real impediments to embarking on a path to implement this model and what it would take in order to achieve it, including things like, you know, estimating the cost of citing. I mean, I hear about available funds, you know, for this purpose. I'm not sure what they are. It'd be great to learn more about that. But knowing how much of a financial commitment is immediately available to pursue this goal, and then realizing what that money would pay for if the state elected to pursue this course, you know, are things that I think are important for us to think about as a work group. Because if we don't ask the questions, someone else is either going to dismiss the concept out of hand because it's too hard or too expensive. But if we come in and tell them, you know, we have a vision for establishing one or more of these centers in the state, here are what we think are the challenges. I mean, you know, if you got $2 or $3 million available, you might end up spending that on R&D alone. And, you know, from an operational perspective, even the costs of making a healthcare facility ligature proof.
So,
you know,
Carl,
cost
can you
millions of
translate
dollars.
it? Can you translate to concrete recommendations for us?
Can I translate what I'm talking about into concrete recommendations? I'd be happy to do that. I'll spare you the time, you know, on the call, but I've cited several, you know, concerns which are already represented in the document, you know, relating to physical space. Even the process of getting, you know, approval to provide services takes time. If it requires some sort of regulatory review, you know, by the Office of Healthcare, the Office of Health Strategy. So we, you know, I think we should talk about what is the appropriate Medicaid rate to reimburse those services? Well, we don't know because we don't really know how much it costs to provide those services.
There's a lot of details in there that you've mentioned that I do think we could potentially call out and say need to be addressed, but certainly that wasn't part of the details that we were given. I think our first parameters are to deliver a model, and then the questions that obviously come right after that is how much does it cost and how would it happen? So I agree with you that those are all the right next questions, but I'm not sure we've been asked to try to solve every challenge that's going to come with a brand new level of care. And there are some new dollars that are available that we know are likely insufficient for building 2 levels of care. But there are also, budget options and conversations that could be going on concurrently with OPM and others. But I think it's important for us to walk through what at least we were originally tasked to do. So we could really spend an awful lot of time thinking about what we would be worried about and what are some of the challenges. And it's not to dismiss what you're saying. Those are all being very real with this. But at the same time, it's a progressive process. So, let's take our first steps and then go from there.
Howard, go ahead.
Yeah.
Sorry.
Yeah, I just want to maybe add some other comments. I think Carl sort of hit on some really important issues. I think it's safe to say that this state is hungry for an immediate response to the crisis that we're all experiencing. And maybe that one of the additional tasks before this group is to not only lay out a recommended model, but as you were saying, Tim, a path to that by recommending also an incremental implementation about what can be done immediately in terms of piloting some aspect of this model so that we can provide the legislature and our leaders some concrete options that they can consider right away that perhaps are more affordable given the availability of resources, allow us to use a pilot to work out some of these complex details, but at the same time, together be able to deliver to the public something specific and concrete where they could acknowledge that we're trying to address the crisis. My concern is that we're going to be offering a very broad, expensive model that the legislature, many of whom are going to look at that and say, we can't afford it and dismiss the whole thing. And I think that there's an opportunity here that we need to grab onto if we do it right. So my suggestion is that we look at a broad model, but recognize that it might be much too expensive. And what can we do incrementally in terms of providing the leadership with some realistic options that would bring us eventually to a scaled up urgent care crisis stabilization program.
Let me follow up on that. Tell me a little bit more. I mean, you've seen the draft model a couple of times. This is the most recent being the one that includes input from our August meeting. But Howard or Carl or anyone else for that matter, which parts of this model do you think would be ripe for early phase implementation? And which elements do you think kind of come later? I mean, obviously the physical site and facility is something that kind of is going to take a little while potentially to happen, but are there pieces of this, Howard, or others that you think could be done early to address the immediate crisis?
I think if we, canvassed this group and our larger community to see which agencies, and first of all, I would recommend that we look at partnerships between hospitals and community providers so that we're not talking about hospitals doing this alone, but there are 2 major components in urgent care that I see as critical. One is addressing the issue of kids backed up in emergency rooms, doing more rapid triage, getting kids out, but also creating an alternative to the community, an alternative to the ED for community members, providers, and such. So I think if we could find, some partnerships around the state that are willing to dive into this and at least start offering urgent care access, even if it's on a more limited basis. It's not 24/7, 365, but maybe, from, 8 in the morning till 8 at night. Just do something creative, sort of innovative, to at least deliver some new ideas to the community that we can then build upon. I think I may be naive, but I think that that's something that could be achieved rapidly if we had the right people who are willing to step up. And it might require initially some grant funding, since we don't have a reimbursement model yet in place. But maybe that would also pressure the our Medicaid folks to move more rapidly in developing a model if we've got a pilot that's already up and running and demonstrates success. Just an idea.
Jeff, if I can chime in there, I agree with what Howard is saying completely, that's an incremental way of starting this. It's essentially, what he described essentially is just, try and get PHPs up and going, where somebody spends the entire day there, sleeps at home at night, but has, child and adolescent psychiatric assessments, involvement regularly, and a lot of clinical involvement. Frankly, as I read the CSU model parameters, I'm hard struck to understand anything in there that's different from an inpatient hospitalization. And I don't see it as building another level of, it is building another level of care, but it's going to be essentially indistinguishable from an inpatient hospitalization, the way I read the description. But I would echo Howard's comments that, that's something that could be done more quickly, is to encourage others to essentially have a day hospital or IOP or PHP model.
I think just to tag on to that, I think the here and now is the first 1 to 7 days after somebody's seen in an ED is the most challenging, and why we end up holding on to them. We don't have a place to go. They usually can't get an appointment within the first 5 days, and it's very hard to coordinate. So not only the PHP, but perhaps something that I think is very important in the urgent care probably, and the CSU, whatever models, is the coordination of care and where people will end up. And I think that's something that is a short-term thing that could be stood up. And I think more importantly, but in addition, is the integration of our electronic medical records with each other and outside community programs for referrals. Giving referrals by phone, by fax, after hours in the evening is very, very time consuming and really delays care. So I think, the coordination of care, but inclusive of electronic referrals and that first 1 to 7 days of something that can kind of take the burden off the patient and the clinician, because many times it's the clinician not wanting to send someone home. They're not comfortable, that they're not going to get seen within the first 3, 4, 5 days. So it's kind of that first, that middle period until they start their actual care. Those things don't require a ton of capital. They don't require new buildings. And they, like Howard said, could probably be functioned off of some sort of grant funding. But I'll be honest, I don't think the hospitals are willing to stand that up on their own. With the many hospitals, including ours, I'll be, we invest a lot into this ourselves. We have 6 social workers in our ED just dedicated to this that doesn't get reimbursed. So I don't know that the hospitals are comfortable going forward and putting more money into this alone.
Okay, so I'm just trying to figure out where to go. This is a surprise. I mean, we've not spent much time talking about the behavioral health urgent care model itself. We're spending our time right now talking about what do we do before a behavioral health urgent care model can come online. And I think to Tim's earlier point, I'm not sure that's precisely the charge of this group. And it's sort of like it's a very different task that goes almost like starting a whole new thing outside of what is on the screen right now. So
yeah, I would suggest, so here's what I would suggest. So I think a lot of the comments that have been made can be added into the context. And I think we could be responsive to the need by maybe a short-term spin-off group from this. But our task still was to deliver 2 models for Connecticut. It was articulated from the beginning on behavioral health urgent care and crisis stabilization. I think there was some hope that the crisis stabilization programs would come online more quickly than any urgent behavioral health care, urgent care center. But both, I think we knew there was some implementation time. I'm hearing, particularly from the hospitals, the need because of the crisis in EDs today. So I'm hearing that loud and clear. That said, if Connecticut is ever to see these pieces put into place, and if we were to shelf this and then focus on the current short-term crisis, which is, again, been now ongoing, we missed the opportunity again to kind of continue to put these pieces into place in Connecticut.
Why can't we do both, Tim?
I'm not, that's what I'm suggesting, but I think we need to finish the work we started, and we can certainly then spin off an additional group to meet, I would think, to just talk about current possibilities. So for example, the suggestion around PHP and IOP, those are well known and established, and we're in other circles, we began to think about how do we get that going immediately, and strengthen that level of care and improve that level of care. So we could certainly add to that by spending some time with that, but we need to deliver some concrete recommendations around BH, urgent care, and crisis stabilization.
Alice, go ahead, please.
Yeah, I just wanted to come out in favor of the big picture. I mean, that's been the charge of this group, I would imagine, to come up with something that we feel makes sense and addresses the things that we're saying are that are evident in deficits in our system. So I think that we do need to push that above everything else. If you wanted to get into the specifics of how to implement it, you could still use the big picture and just focus on a small area, and then try to come up with a mini system that contains the things that we want, and pilot it out in a small circumscribed area. But I don't think we should lose sight of the fact that, we can do small increments here and little things there. We know what how the costs go, but without the big picture, we're kind of like, lost.
Tammy?
Yeah, I'm sorry. I have to admit I'm a little confused, and I think I share some of your, I don't know what I sense, Jeff, this kind of potential kind of derailment. But I would say, like, one of the things that strikes me is that this is not, this would be something new to Connecticut, but this is not something new. And I think the presentations that we received from the other sites suggest that it is indeed possible and beneficial, or at least potentially beneficial, or at least beneficial in other contexts. And, I do tend to think like, hey, if they can do it, we can do it. And I don't discount or dismiss that it will take time and that there are really big, significant questions around the business model. But I know that these in most of the other settings are hospital-based, hospital-driven projects. And I do think without support or commitment from the hospitals, it may be hard to achieve. But I was wondering, we don't have to entirely reinvent the wheel. The existing models and things and psychiatric EDs that have been running for years are not so far away from us. I know that there were questions during the presentations about the initial funding and financing and the kind of reimbursement and finance models. And I know there was going to be maybe some follow-up with the presenters about kind of getting more detail on that. And I think if there was a work group that was looking at the business model, perhaps a kind of a hospital-focused working group that was working on that business model and really understanding what the startup investment might need to be, what the public startup investment might need to be. I mean, I do think that having the kind of numbers data from those other places might be really helpful.
All right, thanks. Gary, I see you had a comment. Do you want to come off of mute and talk about that?
I totally think everything should be on the table, but I would just say there was a time when you couldn't shake a stick and not hit an IOP or a PHP, but they contracted because they, among other things, they financially failed. And so I could just say for our local area, I don't think IOP and PHP has been a solution, and now it's virtually unavailable. But I can't argue that there was a time when it was kind of more plentiful, and I can't remember clearly enough 15, 20 years ago to say that that kept kids out of the emergency department. But I mean, right now, I don't, if it were something that people felt like they could financially make a go of, wouldn't the market already be doing that? So but I do think that it is one of the problems. I just would say I hear everything of what people are saying, and I think this is a complex issue, and I appreciate it. I'm not sure PHP IOP is going to do it for the kids that we're seeing.
Okay.
Thank you.
Frank, go ahead, please.
Yeah, so I think it can help. It still loses money, but it loses a lot less money than other options. Let's face it, the things we heard from Bellevue and the Long Island hospital, it's incredibly expensive. It's hugely cost prohibitive. There's no way that's going to happen in Connecticut that I can see, not without a huge amount of expenditure from the state. The issue is not just in terms of keeping kids out of the ED, at least for us in New Haven, folks are getting seen by psychiatric social workers and child and adolescent psychiatrists, and for those a little bit older by they're being seen, and we could dispo them more quickly if we had a place to dispo them to. We don't have a place to dispo them to, so that's why they're getting stuck. The assessment that we're talking about, it'd be great to do more assessments, but what my worry about this 23-hour assessment is that once you do the assessment, then what? And that's why we're talking about a crisis stabilization unit, but that to me seems identical to inpatient. There's the phrase in the crisis stabilization unit about least restrictive. That's going to have to be a locked setting. That it will have to be a locked setting. It's going to entail all kinds of the legal requirements with probate court and involvement with voluntary or on a physician's emergency. It'll be a locked setting, in my experience in some 10, 15 years ago with St. Raphael, IOP helped. It absolutely helped to keep kids from returning to the ED, or if they did, we could dispo them quickly and get them back into care. And I do think that that's why it should be an option. The concern I have, and I'll be frank, with just the creating more of the urgent assessments is just that, once you do the assessment, then what? And that's the piece that's missing. We're underbedded for inpatient beds, in my opinion. Solnet, what used to be Riverview, really, it's the number of discharges from that facility is probably half of what it was, 10 years ago. We're underbedded. But something, when the question came up about something quickly, expanding IOP, and to answer, I'm sorry, I think Greg from Wellmore, it's reimbursement is just, it's incredibly low. And that's why, I think hospitals aren't doing it. we do it because it helps to move kids through our system.
So I think at this point, we are certainly hearing and registering the tone and the themes. But I think we're also at this point reiterating and restating things. So inpatient and capacity increase, in order to be successful with these two models that we are focusing on. And we're hearing clearly from you, Frank, also that you don't agree that there's two levels of care, a differentiation between crisis stabilization and inpatient. And I think if we're not, then we need to be more clear, because I think the literature certainly does that. And we can, when we get more into the details of crisis stabilization, that would need to be addressed and how they're different. But I do think there is a difference, the biggest one being community-based and with a lower level of acuity, but still maintaining some higher level of acuity than what is normally in a crisis respite kind of setting or a kind of a residential treatment setting. So I think we will defer at this point. We're more than halfway through the meeting on the context, and we'll fill this section out further. We did have the conversation, it's not as clearly reflected here, about the intermediate levels of care needing to be enhanced, bolstered, and expanded, IOP, PHP, EDT, and then again, the context of the bed capacity are all, and in particular, as stated, just to be very clear about it, the state bed capacity. So all those pieces we need to put and put it in the context of the big picture, and we will do that. We'll get this out to you, and we would appreciate all your comments. And again, you don't need to write volumes or lots of narrative. If you're just seeing us miss something, just shoot us a note saying, could you reflect our concerns around whatever it is that you don't see there. But I think at this point, it might make some sense to get into some of the concrete parts of the BH urgent care, just in terms of being able to stay on track with what our original goal was to kind of get that done, and then be able to start to think about populating the crisis stabilization.
Right. Okay, so yeah, so we took a lot of notes. Hopefully you saw as you were talking, we got several things reflected from the discussion relating to context in the full system and the need for short-term solutions before this comes online. And we'll work with the overview and context to make sure that those things are clearly reflected. As we dig into some of the content areas for the urgent care description, do people want to comment at all, either on the goals section or the setting?
I just had a quick question on the 23 hours. I know we've talked about it before, but I was making some thoughts about it. What drives the number being 23 hours? And I think it would be really important that we have something in here that kind of describes what happens on the 24th hour, because I know we're trying to design this around best case scenario. I hear that loud and clear of hopefully the system will work and they won't be there for 24 hours, but inevitably, I feel like we should have some comment on there of what happens at the 24th hour, and previously what drives the 23-hour number.
So again, essentially, if you look around the country, and again, our apologies, because early on we embedded with a lot of that context was embedded in some very large documentation that were put forth by the federal government and SAMHSA in terms of best practices. But the urgent care is just that attempt to be sure that it's not an overnight setting. And it's just, that's all it's about. It's just that it most commonly or frequently, there's kind of a day bed structure, because certainly kids and adults can come in overnight. But it also has a reflection in a lifespan model that we have not spent a lot of time talking about, but a lot of the urgent care / observation centers / sober locations are often have very similar components to it. But the notion was an easy, accessible alternative, and to EDs. And the average, the hope would be, if you're on top of all your assessments, it's a 2 to 4 hour visit, not a 23-hour visit, but that the 23 would be that the goal would be to be sure that a child is discharged before there was any kind of context to having to be in a bed overnight.
I think that's really doable. That very much is doable on the discharge end, but it's what if they need an inpatient level of care? That's I should have clarified, and I apologize. So the discharge, I totally agree. A couple hours, they should be out of there. If it's taking longer than that, we have another problem. But if they need an inpatient admission and there's not a bed available, that 23 hours is what sticks out in my mind. Of sometimes, many times, it takes longer than that to get them in.
Right.
So different than a regular urgent care, right? If you think of medical urgent care, they're not really admitting patients ever, very rarely, right? So this, in some sense, doesn't relate, and maybe it's just my mind to the urgent care model. But how does that work, or would work, or do we need to come up with that?
I don't know for sure, Jason, but I imagine it was a regulatory thing, and it was probably protectionist advocacy on the part of hospitals, so that they weren't actually like competing with the business that EDs wanted. But it's an awesome question to ask, and I think really understanding what there's kind of the intent of the site and what it's really for, and whether 23 hours serves that purpose. I think there's that other question, but I wonder if there's actually kind of a licensing regulatory basis that has to do with, kind of the definitions of the legal structure.
I'll be more clear and transparent. What I don't want to see happen is someone that's admitted in urgent care and it hits 23 and a half hours and they send them to the ED.
That's what's going to happen.
Maybe I should have said that in the forefront. Sorry, but that's my concern.
What I can offer, and what we saw in the presentations before, was that there was an immediate, like a direct connection to an inpatient unit, so that there was direct admission, but it was also, the ones we saw were actually located within a hospital setting in New York. When I've worked in behavioral health emergency rooms, which I know we're calling emergent cares, but that's essentially what they are, before these assessment centers, is that there is a direct connection to an inpatient unit, meaning where I worked before, even though it was a freestanding psychiatric hospital, not connected to a medical, like a medical facility, that there was still that assessment center. Literally, you went through a couple of doors and you were on the inpatient unit. So that's the piece that I do think we need to consider with regards to these assessment centers, is how is there going to be a direct connection? Because we can't have the kids being seen and then they're having to search for a bed in the state, right, in order to place them.
Yeah, but it still should be addressed, because we speaking at Yale, we have how many beds, Frank? We have a lot of beds, and yet I still have 2 kids in our ED that have been here greater than 24 hours waiting for a bed. So we have 70, 80, maybe more. I don't know exactly how many beds, but we still run out. So I worry on a much more global scale, where the beds become more shared, that 23 hours fits into this, and what happens when they can't find a place to be put. But I do agree that they need to have connections. Doing bed searches is like a full-time job.
Yeah, so appreciate all the comments, because again, just bring us back to what we kicked off with and some of the best practice that were put forward. And I want to pause for a second, and let's just put the BH care on pause for a second. If right this second in Connecticut, we had a full crisis continuum, the kids wouldn't be stuck in EDs right now. If we had plenty of inpatient beds, if we had crisis stabilization, and if we had crisis respite, and a more integrated direct admit to all those levels of care with mobile crisis as the center of the hub, which is what this is a best practice for, is that you have a fully integrated and well-functioning system. So direct admit from EDs to inpatient, direct admit to crisis stabilization beds, direct admit to potentially crisis respite beds, discharge home to the community with mobile crisis support and or other linkage to communities. That is essentially your opportunities for discharges. And if that was a full, well-functioning array, currently in Connecticut, EDs would be assessing kids more rapidly and getting the kids out and connected, right? So I think we should acknowledge that. Why we're still saying this is important is that there's still some things that occur in EDs that aren't good and healthy for kids. And so that's why we want to get kids out of the emergency departments and get them to a behavioral health assessment center. So all the issues you're raising for the BH urgent care settings are the same issues that we have today. So we can't build a new level of care without solving the same challenges that we have that exist before that. So none of this was being put forth in isolation of the others. So I think, though, even in well-functioning systems, there are situations where kid shows up in an urgent care setting and they in fact do need to go on to EDs. Now, if that becomes an ongoing, systematic situation, there's obviously a problem that needs to be addressed. But again, I think our task is to try to put the whole picture together and deliver kind of a model for BH care.
Any other comments on goals setting or other sections that people just want to jump to if they're, because I know we have 15 minutes left. So if you have a burning question or comment you want to make about any section of this, let's do that. We're going to have limited time to get started on the CSU discussion, but if you really want to get something in on that, let's open the door for that as well.
I just wanted to make a comment, Jeff. I think in light of the conversations we've had for the last 40 minutes or so, there seems still to be a little bit of confusion about who the target population is and level of acuity that would be targeted with an urgent care model. I think it would be helpful for us. I didn't have a chance to look in this in any detail, but really more clearly define who the target population is relative to acuity. So that we're clear about who it is that we're trying to serve in this model. My guess, to Jason's point, is that if we had an urgent care center, we would be able to determine relatively quickly if a child came in and needed inpatient care. And I do agree that the likelihood is that that kid would be sent to the ED for further assessment and disposition. I can't imagine how a kid coming in will spend 23 hours and at 23 hours, they'll determine that the kid needs to go to a hospital. But I think that's why we need to be more specific and clear about who these kids are. And then what other data do we have to support the volume of kids that are currently coming through our system that meet that definition? EMPS should be able to tell us in terms of acuity level, schools and whatnot, and canvassing maybe the EDs about who the kids are that are showing up that would have been low enough acuity to be seen and cared for in an urgent care center. Yeah. So I just wanted to throw that out.
No, I think it's a good suggestion. I think we can add a section on target population right after goals that gives a little more clarity to that. But I think the end of your comments, I think, were the critical points. We don't have, at least I haven't seen hospital data that shows level of acuity, what percentage of youth that show up to an ED setting that don't need to be there because they're not likely to meet criteria to be admitted to an inpatient bed. But the target population, in my view, at least for the urgent care setting, is that, the national literature at least suggests that anywhere from 40 or even 50%, and some anecdotal conversations I've had with hospital ED staff like Steve Rogers and others have said, anywhere from a third up to a half of youth that present to an ED with a primary behavioral health concern don't really meet level of care criteria to be there because they're not likely to ever need to be admitted inpatient. So the target population is really that group of youth who are in mild to moderate acuity, who aren't likely to be admitted to inpatient and don't need to be in the ED, but they do need some specialized behavioral health assessment, stabilization, and then linkage to a different part of the behavioral health service continuum.
And Jeff, we do have that data. So we have that data in terms of length of stay and acuity.
All right, if you want to send me that, that'd be great. I'd love to take a look at it. And same goes for Yale or other hospitals or others on the line. I'd love to be able to see that.
I think I've seen data that 70 to 80% of kids showing up in EDs in general are discharged home to the community. And again, all the EDs would know that better than anybody, but so there's large populations that seem to be doing that. So
I think that's pre-pandemic data, Tim, that we've seen a dramatic shift during the pandemic in the opposite direction. But I think we can get you the data.
I mean, I could say as a crisis provider, these are moderate risk kids who need more intensive in-home services. So the earlier conversation about ICAPS and MDFT and PHP, that's who these kids are. So we hold them and stabilize them until those services are available. So it feels like those kids to us, although they might be a little bit higher in terms of maybe there's some suicidal risk. There's not a plan, but there's intent. There's, kids who, person who sent them to the ER was worried about their risk to themselves, but it was determined, that they were safe to return home, but the family might be concerned about that. So, EMPS could tell you who those kids are too.
Right.
All right, just getting myself caught up here. All right. Other comments, please.
I just wanted to put in a pitch because I think that the initial contact point for any kid whose state of acuity we don't really know until they hit some assessment should probably go from the more acute setting to a less acute setting rather than the other way around, because you don't want to miss anything medical or metabolic or whatever that might be best triaged through the ER. So I would urge the initial contact point. I mean, we can make it a lot more effective triage and recommend that there's more effective triage, but you might be a lot better off and miss a lot less going from the ED out to the behavioral health acute unit rather than the other way around. You always assume the worst and you rule that out first.
If I may just sort of speak to having been in, an ED on call in the emergency department, as well as CL and in the emergency department as a psychiatrist, they don't get really thorough physical exams when our kids show up, just being real. They might get seen by a resident who will listen to their heart and lungs and keep it pushing, right? And so it's not as if right now our kids are getting thorough evaluations for medical issues. And that I think that if you have psychiatrists, specifically physicians who are employed, not only social workers or clinicians, to be able to assess and rule out any medical issues that would then lead to a triage or sending a kid for evaluation in the emergency department. That might be a more effective route because the bulk of kids don't present with medical complications that could present as psychiatric disorders.
I don't know. I mean, coming from a medical side, you always assume patient comes in with a headache, it's brain tumor unless proven otherwise. So you always try to rule out the worst thing, even though however unlikely that might be. I don't know. I'm not too excited about having. I think I do a good triage, but I would not want to take the place of a neurologist or whoever, or a more comprehensive evaluation before seeing a kid in a less acute setting with fewer medical options available. I'm just saying.
Okay. So I want to note there's a number of things going in the chat box as well. I don't know that we're going to have time to get to everything, but if somebody does want to come off mute and make a comment from chat, also keep in mind we do drop all the chat box content directly into the minutes as well. So we try to log that information and take that into consideration as well. Any other final thoughts on, with the time we have left, on urgent care? Or again, we didn't get to our CSU conversation, but if you have something to say as we start to think about making that pivot, go ahead and comment on that as well. Is anybody else as struck as I was by, and I know we sent out the documents from Massachusetts about their CBAT community-based acute treatment for children and adolescents model. And I know it was short notice because we had, thank you to Tammy for digging that up. She sent that to us yesterday and we thought it was relevant. So we did send it around. I was particularly struck by in the funding approaches section of their model, where they talk about the legislation that took place requiring all payers to pay for that level of care and to establish parity between the public and the private systems. I thought that kind of legislative approach was kind of interesting to funding these models. That's just a invitation if anybody wants to talk a little bit more about the funding approaches or what might be required to make sure that this is robustly funded and doesn't fall apart because of insufficient resources.
Jeff, my understanding that it had to do with political will. At the time that this all happened in Massachusetts, there was also a huge crisis of increased demand, and the governor and the legislature got involved directly in funding this model, as well as funding additional inpatient beds at Boston Children's. So it was a confluence of a lot of political interest and desire to address this issue in a more immediate way that led to the funding of these programs up in Massachusetts.
And Jeff, let me add, it's interesting, we can legislate that, but in my experience, the funding issue is not an issue with the commercial payers. It's Medicaid. The rates are just far too low. I can't quote off the top of my head how much it is, for a 1 hour social work assessment for initial psych eval that we get. It does not cover costs. Far from cover. It doesn't cover costs. And so we can talk about parity, but without getting into the actual rates, then it's not really hitting it. That's our experience on this.
That's helpful. Okay, well, it is 10:57 and that hour went by quickly. So I'm going to ask Tim if he wants to comment on next steps, but from our standpoint, at least, we will take everything that's been discussed here today. We'll continue to work with the model description we have here for urgent care. Anything of relevance to CSU, we'll also drop that into the CSU document. And rather than, I'll let Tim kind of speculate on what seems to be appropriate next steps coming out of today's conversation. But we'll do that piece. Tim, do you want to say anything else about where we go from here?
Yeah, let me just quickly, first of all, acknowledge and just say that the first 30-40 minutes of the meeting, we heard loud and clear. That said, we still would like to move forward with delivering at least some structured recommendations for Connecticut for these two levels of care. So I'd like to plow forward that. I would like to suggest that maybe we spin off a second meeting time in between, like every other. We have 2 meetings left of this group, which was originally what we had intended to try to get that piece done. But maybe rather than waiting and then starting something else, we send out a secondary meeting in between these on the same time, the same day of the week and time on the second weeks, and talk about immediate solutions and maybe just get as many ideas together on that. In doing so, maybe that helps us expand the contextual part of this document up front, and then maybe provide some recommendations, much more concrete recommendations on trying to do things, hearing this group's concerns and hearing this group's recommendation on concrete strategies about what's occurring today. So some of that in the context of what we like to build in the longer term, but it also seems like, I know that those conversations are also occurring in other areas. So we can just add this group's perspective to that. Does that seem like a possibility for folks? And I see Tammy has a response.
Thanks, Tim. I don't have a direct response to that question, although I do think additional work will clearly be needed if psychiatric urgent care is going to go anywhere. I know we weren't able to spend much time on crisis stabilization, and The only question that I wanted to ask was, so we all know the SFITs are scheduled to close. I know to some extent they have been used as a discharge resources for EDs. I'm wondering, particularly from our hospital representatives, to what extent you have identified those as a resource. They are closing. My understanding was that the crisis stabilization units were going to be kind of the next iteration of SFITs. Is that your understanding as well, Tim, or not?
It was the original plan and intent that the repurposing of the SFIT dollars would go into one or another of these two levels of care. Yes. So there is that intent. There is also a need to develop something for the SFIT. So again, the SFITs is Connecticut's version of what was historically referred to as a crisis stabilization. So that notion, I'm sorry, the crisis respite. So the notion a child is in a need of a bed versus acute level behavior is driving the need for the bed. So yeah, again, a full continuum would be ideal. So thank you for that comment, but let's just go quickly with just if people can give a thumbs up either visually or with your yes appetite for a second meeting time in between the two meetings for discussion on exactly what's going on today. Okay, so stay tuned for that. We'll pivot. So we'll look to the calendar in somewhere about 2 weeks from today. And then just we'll spend more time focusing directly on that during those meeting times. And we'll try to just, again, pull together the BH urgent care model and plow forward with the crisis stabilization model and get people's feedback on that in the next couple of meetings. So I do appreciate everybody's joining. I do appreciate all the full transparency and honesty on kind of sharing that. Apologies if you're not feeling we're as responsive as we could or should be, but the kind of trying to do both at this point. So appreciate everybody's involvement. So have a great day and thank you for joining.
Thank you, everyone. Have a great day.